We are live.
Good evening. Welcome to Aios International Masterclass. This we have it every fourth Saturday on various topics, and today we are privileged to have Professor Prem Subramaniam talking to us on the diagnosis and management of optic disc swelling, papilledema or not. The session will be chaired by Professor Pradeep Sharma, who is currently at Center for Sight, New Delhi, along with Dr. Samar Kumar Basak, who is the President of All India Ophthalmological Society. Rashmin Gandhi will be the moderator for the session. We have an excellent expert panel consisting of Professor Abadan Khan Amitava from Jain Medical College, AMU Aligarh, Dr. Ambika from Shankanetralaya, Chennai, Dr. Anne JK from Little Flower Hospital, Angamalli, Dr. Chaitra Arul from Narayan Netralaya, Bengaluru, Mahesh Kumar from Arvind Eye Hospital, Madurai, Professor Rohit Saxena from RP Center for Ophthalmic Sciences, AIMS, New Delhi, Dr. Swati Fuljali again from RP Center, AIMS, New Delhi, Dr. Shubhangi Bhave from Drishti Clinic and Squint Center, Nagpur, and Virendra Sachdeva from LV Prasad Eye Institute, Vishakhapatnam. We also have a series of cases that are being presented by young ophthalmologists, fellows, and faculty, and that will be comprising of cases by Dr. Aisha Reza from Jain Medical College, AMU Aligarh, Dr. Anna Kurian from the Little Flower Hospital, Angamali, Kerala, Dr. Balraj A from Arvind Eye Hospital, Madurai, Dr. Michael Gilhuli from University of Colorado is Prem's Fellow from Aurora, Colorado, US. Dr. Rebecca Dhiman from RP Center for Ophthalmic Sciences, AIMS, New Delhi. Rohan from LV Prasad Eye Institute, Vishakhapatnam. We have Shushruth Dogargaonkar from Shankanetralaya, Chennai, and Shweta Karnavi from Narayan Netralaya, Bangalore. And that's the elaborate program that we have. Of course, we also have Dr. Sally Jod from Nagpur. And I'll invite Rashmin to introduce Prem, and then Prem will take over. Before that, I request Professor Sharma to say a few words. Rashmin?
Thank you, Dr. Santosh. I think it's really a privilege to have a grand master like Prem Subramanian to be enlightening us. Unfortunately, neuro-ophthalmology in India has been in the background, actually more posterior than the posterior segment, with very few ophthalmologists really well-versed to do any basic assessment in neuro-ophthalmology. It's sometimes very sad to see cases like just last week, I had a case of NF2, a bilateral acoustic neurinoma, who was having deafness. So he was referred by a ENT specialist to a neurosurgeon. The neurosurgeon timed the surgery, which was delayed by 2 months. Nobody bothered to look into the fundus, and he kept on losing vision gradually, silently. So when he started complaining of vision loss, he was sent to an ophthalmologist who again started homeopathic doses of Diamox, 250 milligram BD, and the vision further dropped to finally counting finger when he came to me 2 days back. It was such a sickening thing to see that now he's bilateral deaf and almost bilateral blind. So this sort of thing, I think, is something which we need to take care of. And it's very heartening to see Aios doing a tremendous job in sensitizing at least the ophthalmologists, and of course, someday we may be able to do other allied specialties like neurosurgeons and neurologists in India too. Such great master classes by international masters are there, and today we have Dr. Prem Subramanian, along with interesting case presentations by several young faculty members and neuro-ophthalmologists, and then we have the expert panel by some of the best neuro-ophthalmologists in our country. So I think we are going to have a real feast in neuro-ophthalmology, and we look forward to it. Thank you. Thank you once again, Aios.
Rashmi?
Thank you so much, sir, for the kind words, and thank you, Santosh and All India Ophthalmological Society for involving me in this very well-crafted program. It's an absolute honor to have Dr. Prem Subramanian with us today, delivering a masterclass in neuro-ophthalmology. I had a good fortune of training under him as an observer a few months way back. And one thing which really came out when I was spending time with him when he was in Baltimore was his passion for teaching. He would have his full day in OPD, but he'll make sure that at the end of the clinic, he'll sit down with all the trainees, the fellows, the residents, the observers, the medical students, to make sure that he'll go through every patient that was seen during that clinic, and to discuss and also seek opinion, and discuss why he managed a particular case in a particular way. And he'll make sure that if he was busy with a meeting uh, after the clinic, he'll make sure that those clinic rounds, those file rounds, is continued the next day morning. So that passion for teaching now also is seen. He travels extensively to train. He has come to Aios many times. He has never refused the invitation, either online or even travels for just 12 hours to deliver a lecture, to be with us here in India, and goes back. Similarly, he has trained and has sort of developed neuro-ophthalmology in a lot of countries. His fellows are now doing great work in neuro-ophthalmology in countries like Vietnam. He is currently a chief of neuro-ophthalmology and a vice chair for academic affairs in ophthalmology at School of Medicine in University of Colorado. He's also Clifford R. and Janice N. Merrill Endowed Chair. He holds this chair in ophthalmology at the university. Apart from this passion for teaching, he's also very good at administration. He's managing and helping a lot of organizations. He's the immediate past president of North American Neuro-Ophthalmic Society, that is NANOS. He also holds the council position, a very important position, as an admin position in American Academy of Ophthalmology. He has done his medical schooling, PhD from Baylor College of Medicine, and he had his fellowship at Wilmer Eye Institute at Johns Hopkins under Dr. Neil Miller, with whom he has now edited a very famous Walsh and Hoyt's book. They condensed it in Essential of Neuro-Ophthalmology, and now I think 3 editions, both Prem and Dr. Miller have published, and that's one of the book to go to at any level, especially for residents and for fellows, because they've condensed that entire knowledge into one volume. And then that's really very good. So Prem, thank you so much, as always, to join us and enthrall us with your lecture. Over to you, Prem.
All right, thank you very much, Rashmi, for that kind introduction, to Santosh for the invitation to speak to everyone today. And over the next 45 minutes or so, what I would like to do is start out with a little bit of research that we have done into the question of how you distinguish papilledema from pseudopapilledema, and then go into more of the clinical side of things and discuss, and I look forward to the cases that the trainees will be presenting as well. And again, I thank Aios for putting on this program. I have no relevant financial disclosures regarding the matter I will talk about today, and the research that I will start out talking about was really done in collaboration with Masoud Agsefard in Tehran and Bob Rich in New York City. Let's just start with the case. A 26-year-old woman here who has had migraine with aura since she was 15 years old, and now she reports she is having new daily headache. And she maybe says it's worse in the morning. It doesn't really change with position. She reports that she gets tunneling of her vision, but no real obscuration. She has no diplopia. She's light sensitive. She takes a triptan for her migraine headache and an oral contraceptive pill. She drinks a beer daily, takes no other drugs. And her vision is normal, 6/6. She has no RAPD. Her eye movements are completely normal. The front of her eye is fine. But when we look in the back, we do see that there is abnormality of the optic disc. Now here, I think there is no question that these optic nerves are abnormal and swollen. You can appreciate that there is obscuration of the border of the optic nerve here. There's obscuration on the fellow eye as well. There is some obscuration of vessels. So it is not a challenge in this particular individual to decide that she has true papilledema. You get a visual field test. It shows in the left eye where the papilledema was a little bit worse, that the blind spot is enlarged. She has no other scotoma in the setting of this mild papilledema. And we will return to what the clinical approach is to a patient like this. But let's take a step back. It's not always so easy to discriminate papilledema from pseudopapilledema. And if you look at the images on the left and the right, they are very straightforward, very easy. The one on the left is a normal optic disc. The one on the right clearly swollen, there's peripapillary hemorrhage. You are not going to mistake that for anything but abnormal. But how about the one in the middle? The optic nerve is very small. The actual optic nerve is small, and it has this halo around it, but there's no obscuration of vessels. And in fact, this optic nerve had pseudopapilledema. There was no true disc swelling, and followed over time, the appearance of this optic nerve remained the same for several months and even years. So that's the first point I will leave you with, is sometimes time is our friend. And after all the things I show you today, you may just end up seeing these patients in serial examinations to decide if they truly have optic disc swelling or not. But are there other tools we can use? We don't want these patients to disappear from our care. They may choose not to come back or be unable to come back. Are there things that we can do that will help us? Well, of course, on a good fundus exam, you may see that this patient has optic disc drusen. They are very obvious in this particular instance, right? You can see them here in the left eye, nasally. You can see them here even in the right eye. But and so that may or may not be the case. Here again, we have true papilledema, right? There's no question that these optic nerves are swollen. There's obscuration of vessels. There is marked elevation and even obscuration of details over the disc itself. But how about these discs? You see that there's a feathering of the retinal nerve fiber layer, but there's really not an obscuration of vessels. The large vessels are visible. The small vessels are visible. Are these optic nerves truly swollen? And in fact, this can present a challenge to us. Now, this is not a new problem. You can see the date of this study, 1962, by Bill Hoyt, over 60 years ago. He published a series of optic discs where it was presumed, and again, this is well before diagnostic imaging, right? We can see that there are photographs of very abnormal looking discs, normal discs on the left, true swelling in the center, but then on the right, discs that provided a challenge in terms of the diagnosis, small discs with an anomalous insertion, things that were difficult to decide cleanly if this is papilledema or not. And so people have done a number of studies over the years, applied a number of techniques over the years to try to discriminate a truly swollen optic disc from those that are not. And several years ago, there was a study published in the Journal of Aios, because this is often a problem that arises in children. Children will go in for a routine examination and their optic discs will be examined and found perhaps to be abnormal in appearance. Again, unclear if it is truly swollen, but still a concern. And so if you look on the left, this is something called multicolor imaging that uses false color images to try to separate out signals coming from the fundus as you image it. And you can see that the arrows are pointing to hyperreflective rings that we see in individuals with papilledema. And the middle shows another example of true papilledema with the hyperreflective rings. But if you then look to the right, these are images where on the top, this is true swelling, and the three images on the bottom are elevation alone. I think it is somewhat difficult to discriminate if I didn't tell you that the three on the top were swollen and the three on the bottom were not. If you look at, say, image A and image A right here and image E, I don't think there's a lot of difference between those. And so even with these advanced imaging techniques, it can be hard to discriminate between these two entities. So how are we going to approach uncertainty, right? Again, I showed you that there are times where one optic nerve is clearly abnormal, or both optic nerves are clearly abnormal. In those instances where that is not the case, how are we going to approach this uncertainty? One method that has been used over the years is B-scan echography, B-scan ultrasound, because it is freely available in many of our clinics. And so when we look at B-scan ultrasound, you can see that there is optic disc elevation that is shown by the yellow arrow, and that is non-specific. But then you can see that there is, where the red arrow is on the left, that there you can visualize fluid CSF within the perioptic nerve sheath. And the middle and the right images demonstrate that you can use a scan to measure the width of that CSF space within the optic nerve sheath. And when the patient is looking straight ahead is shown in the middle, and when the patient is looking 30 degrees temporally is shown on the right. And so the idea is that when the patient turns their eye, the CSF space should collapse. And if the CSF space is enlarged, it will still collapse. And so you're looking at the difference between what the space is looking straight ahead and what the space is when they look to the side. And you can, if there is a collapse that is felt to be positive, in normal cases, you don't really see much collapse. Well, this was I had looked at this years ago, and this was a study published out of University of Pennsylvania, where they looked at patients with true papilledema and pseudopapilledema as determined by clinical examination and other factors. And what they found was this test is unfortunately not very good, because if you look at pseudopapilledema in the right column there, 50% of pseudopapilledema gave a positive 30-degree test, a collapse of that perioptic space. And so the sensitivity and specificity were really in the 50s or 60s, with a positive and negative predictive value, again, only in the high 50s. This is almost equivalent to flipping a coin. And so I think that unfortunately, this technique is not the most helpful in trying to distinguish papilledema from pseudopapilledema. So what else do we have in our armamentarium? And some of this discussion started when Masood was a fellow with me many years ago. And we talked about how we could perhaps use more advanced imaging to try to discriminate these entities. And so one of the things we decided to do was look at OCT, right? And so if you look at OCT, these are two images from a paper we published now 10 years ago, looking at the standard retinal nerve fiber layer thickness calculation between an individual who has papilledema, and this again, it's mild, right? I didn't mention at the beginning that, of course, when you have higher grades of papilledema, Fresenius grade 3, 4, or 5, I did not include that in this talk, but if you're talking about papilledema where vessels are clearly obscured, off the disc, on the disc, there are disc hemorrhages, those features I showed you at the beginning, there is really no challenge in trying to discriminate these two. It is in these cases of subtle papilledema, grade 0, 1, maybe grade 2, where it is not as obvious that we run into our problems, we run into the challenges about telling these two things apart. And so one of these optic nerves is swollen and one of them is not. And I'm not going to tell you yet which one, but when you look at the retinal nerve fiber layer thickness, the peripapillary RNFL, we find that one of them has a thickness of 119 microns and one of them has a thickness of 116 microns. Which one is truly swollen? We can't tell from the OCT of the retinal nerve fiber layer alone. It would mislead us into saying one is abnormal or one is normal. If you then take the macular algorithm and center it over the optic nerve, you start to see something a little bit different, right? Qualitatively, you can appreciate that there is more white in the image on the top, and that there is just maybe a wider area that is thickened in the disc shown on the top than the one on the bottom. And I think many of you are now going to start to determine that the one on the top has true papilledema and the one on the bottom has pseudopapilledema, despite the 3-micron difference between the two. And at this point, again, this was 10 years ago, we looked at the volume that's calculated out of this inner ring from the macular thickness analysis, again, placed over the disc, and then an outer ring volume that can be calculated, again, in both instances. And again, qualitatively, I think you can already see that the inner ring is maybe not a lot different between the two, but the outer ring does seem to be. And we calculated both a thickness and a volume, and the volume was more sensitive for discriminating between these two entities of papilledema and pseudopapilledema. So again, going back to retinal nerve fiber layer thickness, there was a lot of overlap between individuals who were in the true papilledema group and individuals who were in a pseudopapilledema group. So we compared controls, pseudopapilledema, and papilledema here. If we then look at that inner volume, as I demonstrated to you qualitatively, complete overlap, right? There's no discrimination in that compact area immediately around the optic disc itself. So that's not particularly helpful. But again, because pseudopapilledema tends to be compact and concentrated on the optic nerve head, and papilledema, the thickening spreads out more from the optic nerve, you can see that if we set a cutoff of 2.2 cubic millimeters of volume, we had a decent discrimination between pseudopapilledema and papilledema. Not perfect by any means, but it identified papilledema very well, and there were only a few cases of pseudopapilledema that crossed over into the papilledema group. So some initial work that demonstrated to us that imaging and using the imaging tools perhaps in a way that was not quite the same as being used in a standard clinical technique could be helpful to us in trying to discriminate true papilledema from pseudopapilledema. I showed you the use of a macular algorithm placed over the optic nerve. What if we actually look at the macula in individuals who have papilledema and compare it to pseudopapilledema? So again, one of the things we looked at in this study was we were looking at the Brooks membrane opening to see if there was a difference in the size of the Brooks membrane opening between those individuals with papilledema and pseudopapilledema. It had been suggested at one point that individuals with pseudopapilledema have a smaller Brooks membrane opening, and that is the reason why there is heaping up of retinal nerve fibers. But we were unable to find that there was actually a consistent difference between these individuals. And so there was, it was not a reliable method for distinguishing between these two entities. And remember, the presence of pseudopapilledema does not protect you from developing papilledema in the future. In any event, if we look here now at the macula, so this is a macular thickness analysis done in individuals with papilledema on the top and pseudopapilledema on the bottom. And what we appreciated was that there was a dropout of signal in the ganglion cell complex temporally in individuals with papilledema when compared to those with pseudopapilledema. Now, this is work that we are continuing to evaluate, and I will not be presenting today about some work on AI algorithms that we are performing right now, but we wonder whether or not AI algorithms that we and others are developing may be looking at this change in macular ganglion cell complex thickness. Again, these are people with completely normal visual fields. They don't have visual field loss. Whether this difference may be one of the ways in which an AI system may be able to better discriminate papilledema from pseudopapilledema than we might on our standard clinical examination or by manual examination of OCT images. I showed you photographs earlier on of optic disc drusen. And now optic disc drusen, we know, are not always detected fundoscopically. They're not always detected on color photography. And OCT has been used for a number of years now, especially spectral domain OCT. It does not always have to be enhanced depth imaging as is available with some of the commercial entity or some of the commercial instruments, but you can see here this arrow pointing to optic disc drusen as they appear in a cross-sectional spectral domain OCT of an optic nerve head. They lie within the Brooks membrane opening, defined from here over to here, but you can also appreciate that there is this elevation, this opacity, which has been identified as not being drusen, of course, but being something that has been named a FOMS, a peripapillary hyperreflected ovoid mass-like structure. There is still some disagreement as to what exactly a FOM represents, whether FOMs are folded retinal nerve fibers or something else, but they are clearly not drusen, and they can be seen in any individual with an abnormal optic disc, pseudopapilledema, true papilledema, optic disc drusen, and others. So don't mistake that for disc drusen. These are 4 cross-sectional images of 4 different optic discs, again showing how these hyperreflective lesions with a hyporeflective core can be seen somewhat deep, somewhat more superficial, and they may just also be seen as little hyperreflective lines. The diagnosis of optic disc drusen by OCT a bit of an art. And I encourage any trainees who are on this, who are viewing this, to really look at many OCT cross sections to get better at identifying the disc drusen in this way. Because remember, the retinal nerve fiber layer thickness is not of the greatest assistance in discriminating papilledema from pseudopapilledema. Autofluorescence photography is lovely when it works, right? When we see it on the left here, this is a beautiful example of optic disc drusen and the hyper autofluorescence associated with them. But when the disc drusen are buried, then we are not really going to be able to see them. And then, of course, macular autofluorescence is not a great discriminator between individuals with papilledema and pseudopapilledema. Before I move on to talking about OCT angiography and work that we've done in that area, I want to address a study that was done in 2017, which suggested that OCT was not in any way a reliable method of discriminating papilledema from pseudopapilledema. And what I want to emphasize in this particular study, again, these are respected colleagues and friends who did this study, is that it is easy to misdiagnose those FOMs, if you see in CNF there, as being optic disc drusen, as opposed to being abnormalities that can be seen with papilledema or pseudopapilledema. And so one result shown in terms of retinal nerve fiber layer OCT is that, of course, in pseudopapilledema, there may be damage from optic disc drusen or other prior swelling in true papilledema, and RNFL also can be misleading if you don't have all of the information to evaluate your patient properly. And so it is critical that we don't take OCT in isolation. And I think that that's a key in anything in medicine, anything in ophthalmology, is that we cannot rely simply on one test. These are adjuncts to other things that we are doing on our clinical exam and that we do with our ancillary studies. Does OCT angiography have the potential to improve our sensitivity and specificity of discriminating papilledema and pseudopapilledema? I won't spend a lot of time talking about OCTA artifacts, but just to mention that there are a number of different artifacts that can occur, linear artifacts as shown in C, dropout artifacts as shown in B, and then a variety of other imaging anomalies that have to be corrected for when we look at OCTA. And that's no different when we're looking at OCTA of the disc compared to OCTA of the macula. Adaptive optics techniques have been used to try to deal with some of these artifacts. And so you can see between A and B, when you use adaptive optics, an apparent narrowing in a retinal vessel now looks better. C gives us better visualization, or D gives us better visualization of capillaries that seem to be dropping out in C and things of this nature. But all I'm going to say is adaptive optics requires an incredible amount of computing power, and this little square area is what is being represented in those images on the left. And so you can imagine if you were trying to do an analysis of a patient's macula, it could take a tremendous amount of time, not to mention, again, on the optic disc. So this technology is coming along with the additional computing power, but we'll see how this helps us in the future. But until that time, we have been doing work where we have been looking at OCTA on the optic disc. And one of the barriers that we face when we look at OCTA, and you can think about this, when you look, how do you identify true papilledema? Well, you identify that there's obscuration of vessels, right? That's one of the things we use. But then if there is retinal nerve fiber layer swelling and it starts to obscure the large vessels, then the OCTA is, that's great, but then that is not necessarily sensitive, right? We can see that with our own eyes. If we subtract the large vessels out and we try to look at the retinal peripapillary capillary images, can they tell us something about what is happening at the optic disc? Is there a change in either papilledema or pseudopapilledema? We were looking at this more broadly of any type of optic disc swelling, looking at NAION as well as optic neuritis. But you can see in the 4 columns there, on the left is what the commercial software does, overlaying rings around the optic disc, one trying to delineate the border of the disc and the other at a standard distance. We instead, in column 2, took 1.95 and 3.45 millimeter diameter circles and superimposed them on the optic disc, centering them on the optic nerve. And then in the third column, we show the major vessels that are going to be subtracted out in terms of the analysis of the peripapillary capillary layer. So taking those large vessels out, which can dominate and can give you false positive or negative in terms of trying to discriminate normal from abnormal. And then in 4, there's a calculation. The fourth column is a calculation of the capillary density, again, with the idea that in disease state, are the capillary densities changed in a way that allow us to discriminate, again, papilledema from pseudopapilledema, from optic neuritis, from NAION. Pseudopapilledema and papilledema are the hard ones, right? Because they're usually not visual dysfunction, where there's often visual dysfunction or should be visual dysfunction in optic neuritis and NAION. And this is just an example of how in the center, those vessels are skeletonized, the large vessels, and then subtracted from the peripapillary capillary densities as shown on the right. And this is just another example of an individual with true disc swelling, and how we subtract out what is seen on the disc itself, because there will be obscuration of capillaries by any swelling that is truly present within the optic nerve head. So we published some work on discriminating papilledema from pseudopapilledema using OCTA. We had 41 eyes of 21 patients with papilledema and 15 patients with 27 eyes having pseudopapilledema. We looked at patients with an acute diagnosis of papilledema to try to exclude any capillary loss that could happen because of chronic papilledema and axonal loss in patients with longstanding disease. And we compared these two groups to 44 control eyes. And what we found was when we compared the commercial software to our customized analysis, as I showed you, the commercial software would say that controls and pseudopapilledema were the same in terms of that peripapillary capillary density, and that papilledema had a lower peripapillary capillary density. But you can see in that middle there, right, that we point out that there is obscuration of vasculature by the swelling, and that lowers that calculation of the vessel density. If we then use our customized software, instead what we find is actually that papilledema and controls overlap, and pseudopapilledema has a lower peripapillary capillary density. We don't yet understand exactly why that is, but it was a clear discriminator between them. And so we found that commercial OCTA differed markedly from custom OCTA and poorly discriminated papilledema from pseudopapilledema in a commercial algorithm. And so we are doing ongoing work now using OCTA and AI, as well as regular OCT and cross-sectional images in AI, to try to come up with systems that will be more sensitive and specific in terms of telling these entities apart. So that's the scientific side of things that we're doing to try to discriminate papilledema from pseudopapilledema and develop more tools to allow us to take good care of our patients and not to subject them to unnecessary testing, excessive MRIs or lumbar punctures or even medical therapy if they have pseudopapilledema, and then to more quickly identify those individuals who have true but subtle papilledema so we can help to manage that before they get into potential trouble because of their disease. So let's go back now, and we're going to switch gears again to the clinical side of things and talk about what we are going to do once we decide an individual does have true papilledema. This is a different case of a 30-year-old woman who had a BMI of 41. So I did not talk about the risk factors for developing papilledema, but I think most of you know that the most common condition in North America and the developed world, and I think unfortunately in the developing world as well, because of the introduction of fast food and other calorically rich foods that people are eating, is obesity. And obesity in women between the ages of about 15 and 45, typically from menarche to menopause. These are the highest risk individuals for developing this disease. So this was a woman with a BMI of nearly 41. Remember, 20 to 25 is normal. 25 to 30 is overweight and over 30 is obese. In North America, 2/3 of people are overweight or obese. In any case, this individual had 1 year of transient visual obscurations and headaches. She had some decreased vision in her right eye for some months. She had 630 vision eccentrically in that right eye. She was 6/6 in her left eye. She had a 3+ RAPD, and she had bilateral optic disc swelling. You can see that from the OCT, that the retinal nerve fiber layer thickness scan is well above the green here, and that it is showing us, in fact, the analysis of a very thickened retinal nerve fiber layer in a patient like this with grade 4, grade 5 papilledema fails because the instrument just doesn't know where the landmarks are anymore, but it's clearly abnormal. And so this individual was referred to us. She from an outside doctor who was some hours away, and they were sent with no workup. And so they were sent, oh, this patient has pseudotumor cerebri, idiopathic intracranial hypertension. Please see this patient. She's lost vision in her right eye and she needs an optic nerve sheath fenestration. Well, before we went to an optic nerve sheath fenestration, and I'll come back to that as a treatment, what's the first thing you should do? You should get an MRI scan or at least a CT scan in an individual like this in order to exclude the possibility of this. This is what she had. She had a very large intracranial tumor causing obstructive hydrocephalus, and that was the cause of her papilledema and the cause of her vision loss as well. This is biased toward the right side, and this tumor was also to some degree directly compressing her right optic nerve, causing a combination of a compressive optic neuropathy. This would have led, if she developed optic atrophy on that right side, to a true Foster-Kennedy syndrome with elevated intracranial pressure and optic atrophy of one optic nerve, papilledema of the other. So please don't make presumptive diagnoses of IIH in patients without an imaging study being done. It is then necessary and appropriate to get lumbar puncture. Lumbar puncture in obese patients is not going to show an elevated opening pressure just because of obesity. Studies have demonstrated this, and so it is important to measure the pressure in the left lateral decubitus position. This image on the right is not quite accurate because the patient's legs should be extended when the pressure is being measured, although you can start with the legs knees flexed in order to make it easier to do the lumbar puncture. But ultimately, if you get elevated opening pressure, you should be concerned that that truly is abnormal, even in an obese patient. Well, how should we treat these patients, the majority of them who have papilledema? What has guided our treatment for a number of years now have been the results of the IIH treatment trial conducted in North America as a double-masked, randomized, placebo-controlled trial of IIH treatment. These individuals had mild pseudotumor cerebri. The print is very small there, but it shows that the individuals who were enrolled had a mean deviation on visual field testing of -2 to -7. So they had to have a visual field abnormality, but it could not be too severe. They were randomized to study drug. Remember, placebo-controlled, so either acetazolamide or placebo, unknown to the patient or to us. That study drug was increased up to 4 grams per day, pretty hefty dose. And the outcomes were compared at 1 year. They were supposed to have long-term follow-up out to 5 years, but unfortunately, the funding to do that long-term study fell through, so that didn't happen. The baseline characteristics of individuals in these two groups were very representative of IIH in North America. So a BMI of 40 in both groups. Now, again, I know that in India, the patients who develop IIH tend to have a BMI more in the high 20s, but I think that's, again, a differentiator from the population norm. I told you that 2/3 of people in North America have a BMI above 25. And so, again, although this was a different population, I think it is applicable to countries where the BMI of patients who develop this disease is less. What was demonstrated in this study was that the individuals who were treated with acetazolamide, shown in the top row of circles, had a greater improvement in their mean deviation than those who were treated with placebo. Now, I should state that everyone in this study was also enrolled in a structured program of weight loss, because we know that in again, the vast majority of our individuals who have idiopathic intracranial hypertension, that weight loss is the critical key to ensuring that their disease goes into remission. And so the acetazolamide gave an incremental effect over weight loss. Both groups lost weight, but acetazolamide led to a more rapid improvement of papilledema, especially in those who had higher grades of papilledema to begin with. And combined with weight loss, it was more effective than weight loss alone. There was also an effect on quality of life, that individuals who were given the acetazolamide reported a greater improvement in their quality of life, and those with more severe vision loss or papilledema might benefit even more. Now, again, this study did not look at individuals with greater degrees of vision loss, with moderate to severe IIH, and we'll come to that in just a moment. But typical IIH patients at this point, I think I want you to take away that they all need neuroimaging. They need a lumbar puncture to look both for the opening pressure as well as the CSF analysis. Remember, to make a diagnosis of idiopathic intracranial hypertension, you need to have a normal CSF analysis. The acetazolamide is an adjunct to weight loss. And I didn't get into the fact that headache may need other therapy, but at the end, the panelists may have an opportunity to discuss that. I will come back. Remember, we talked about discriminating papilledema from pseudopapilledema in the first part of my teaching today. Can we have IIH without papilledema? And if so, again, how does this figure into that effort to distinguish papilledema from pseudopapilledema? We talked about that, and I won't come back to it. Rather, I want to talk about what we do in a case like this, where we are referred as ophthalmologists. A woman in her mid-20s, she is quite obese, as you can see, with a BMI of 56. And she has a history of some psychiatric and neurological illnesses, and she has developed new headache. She does not have pulse synchronous tinnitus, often a symptom of elevated ICP. She has no family history of migraine headache. However, she has blurred vision, she has monocular diplopia, and she has no transient visual obscurations. She had a normal ophthalmologic examination with normal perimetry, motility, alignment, but she did have elevated optic discs. It was unclear if they were truly swollen or not. She had spontaneous venous pulsations that could be observed, and spontaneous venous pulsations in the fundus adjacent to the optic disc or on the optic disc are often, but not always, a reassuring sign of normal intracranial pressure. No vessel obscuration. I show you her sagittal MRI because I'm going to show you that sometimes an evaluation of the sella turcica, shown right here, can be a way of discriminating, or at least raising your suspicion that an individual may have true papilledema or truly elevated intracranial pressure rather than just pseudopapilledema. Remember, this patient has elevated optic discs. She underwent a series of MRI scans, and there have been imaging abnormalities that have been proposed to be quite specific for individuals who have elevated intracranial pressure, or sensitive at least for the detection of elevated intracranial pressure. And so some of these signs, and I think many of you, both my experienced neuro-ophthalmology colleagues as well as the trainees, have seen MRI reports where the radiologist will say, oh, there's flattening of the posterior globe on a sagittal MR image as shown here through the globe, or that there is an empty sella turcica as demonstrated here in the top right image with the pointer, or that there is widening of the perioptic sheath, the fluid space in the optic sheath as seen on a T2 image. Remember that fluid, whether it's vitreous shown here in the eye or fluid along the optic nerve, that fluid is bright on T2. And then finally, a sign that I think may have some greater specificity is narrowing at the distal transverse sinus, sigmoid sinus junctions. This is an MR venogram. This is the transverse sinus coming across here where my pointer is, and then the arrow is pointing to a focal narrowing or a focal stenosis within that distal transverse sinus before it transitions to going into the sigmoid sinus. And so that may be a way of truly identifying an individual who does have elevated intracranial pressure. And why is that important? Because that may then prompt you to go back and look at the fundus again of that patient to say to yourself, I thought it might have been pseudopapilledema. Could there be some papilledema there. Now, one thing to keep in mind, and that I have learned, and that I'll show you in the next slide is important, is that once these signs appear, they may not go away. And so when the sella turcica enlarges, for example, or when it becomes empty, even if the underlying intracranial pressure problem goes away, that sella will be empty from now forever. Similarly, if there was increased intracranial pressure and it opens that optic nerve sheath, the optic nerve sheath exhibits something called hysteresis, which is where if you stretch it beyond a certain point, it cannot return to its pre-stretching state. So like a balloon, if you blow up a balloon past a certain point, if you let all the air out of the balloon does not shrink back down to its previous state, it stays a bit larger. So remember that not all of these changes are reversible, even if the underlying pressure problem goes away. So there was a study that was done, published in 2021. It was conducted at Emory University, and what they did is they looked at a number of different patients, almost 300 patients who were undergoing MRI, and they looked at their MRI and they looked at fundus photos on these individuals. And the reasons for MRI, only a small number were undergoing MRI because they were suspected for having pseudotumor cerebri, idiopathic intracranial hypertension. About 9% had headache. About a quarter of them were having tumor surveillance. And what did they find? They found that nearly 50% of individuals had one of those signs of elevated intracranial pressure. A full third, 33% of them had an empty sella, and even 11% had perioptic fluid, and few had globe flattening or transverse sinus stenosis. So maybe globe flattening and transverse sinus stenosis are more specific signs because they are adjacent to the eye of truly increased intracranial pressure, but these other signs did not seem to be very specific, and only five of these patients had papilledema. So what does this tell us? I think this tells us that MRI is very helpful. It's important, right? I mentioned to you at the beginning that it is important to incorporate MRI in the initial analysis of our patients where we see true papilledema to ensure that we do not overlook a true intracranial mass or some other abnormality that needs urgent intervention. But then if we look at the idea that we are going to be able to tell apart those individuals with pseudopapilledema from papilledema by using MRI, and if we rely upon these MRI signs, I think we are going to be misled. We may overdiagnose true elevation of intracranial pressure and put patients through additional diagnostic testing and perhaps even unnecessary treatment if we rely too heavily on these signs. So I think it is, again, it shows us that it is critical as ophthalmologists that we are able to correlate what we see in the fundus with what is present on an MRI scan, and that we use our combined skills to be able to interpret all of this information to tell these two entities apart. And sometimes, again, it is time, it is serial examination. Keep in mind that most patients, fortunately, with true papilledema and elevated ICP, especially if they have such mild papilledema that you are having a hard time deciding if it is papilledema or pseudopapilledema, you generally have a little bit of time to try to do serial examinations or serial visual fields or OCTs to see if there's change over time or not that helps you to be more confident in your diagnosis of papilledema or pseudopapilledema. I will finish by simply emphasizing that there are times when it's time for action and not time to do research or time to do serial examinations. This was a 25-year-old, otherwise healthy woman with a BMI of 41, typical IIH patient, right? She developed headache, then transient visual obscurations in her right eye. She presented to an emergency department, was sent to our clinic. I didn't convert the vision, sorry, but she had vision of 618 and 612 approximately with no RAPD. But she had horrible visual fields, right? You can see that she has blind spot enlargement, arcuate defects. She has significant vision loss from this terrible papilledema. Again, the machine completely gives up. This is grade 5 papilledema bilaterally. It can't deal with segmenting this, but it also shows you that this patient's papilledema was bad enough that she was developing a little bit of macular fluid, maybe contributing to some of the decrease in central visual acuity, but nonetheless, this was a patient where we are not going to well, we're going to do an MRI to make sure she doesn't have a tumor. But after that, we are not going to sit around and say, should we put her on acetazolamide? Should we watch her? Wait for her to lose weight? What are we going to do? We need to do something surgically in this. And so I'm going that my 10-second discussion of which surgery is best. There are 3 surgeries that we typically offer our patients. I put venous sinus stenting as a surgery because it is a procedure. It is often done under general anesthesia and it requires surgical expertise. But if we compare in our minds optic nerve sheath fenestration, ONSF, CSF diversion, and I include both ventriculoperitoneal and lumboperitoneal shunts in that category, and venous sinus stenting, which one is best? The short answer is we don't know. The best one is the one that you have access to, the one that you can get done quickly. So I do optic nerve sheath fenestration, so I can take the patient to the operating room in 30 minutes if they haven't eaten. CSF diversion is harder because I need to get my neurosurgeon involved. Venous sinus stenting, again, has to go to my interventional neuroradiologist. But ultimately, I didn't have photographs from the preoperative state, but postoperatively from optic nerve sheath fenestration. The papilledema 2 days later is already markedly improved. You can see that there is lipid deposition going into the macula along the areas that previously had significant fluid within them. Remember, this is a hemistar that is very characteristic of swelling from papilledema and not a 360-degree star like we see in individuals with neuroretinitis. And her visual fields improved to here. So her right eye, which was the worst eye, she still had a little bit of a scotoma. Left eye is nearly normal. And again, we can appreciate just the dramatic improvement that you can get in patients by intervening in an appropriate and quick manner. The last thing I will leave you with is sometimes we will see unilateral true papilledema in individuals who develop a problem called CSF sequestration. You could have elevated intracranial pressure and have only one optic nerve be swollen. And that is thought to be because of anatomic anomalies here in the left eye in this patient, where the pressure intracranially is not transmitted all the way to the optic disc, and in fact leads to a protection of the optic nerve and it never swells. Whereas on the right, there's visual field loss and there is significant papilledema. And the macular ganglion cell complex is normal in this individual, but there was persistent swelling within the nerve on the right side, and the patient was starting to have some visual field loss, as I showed you. And so we did optic nerve sheath fenestration on the right eye only in this individual because of the CSF sequestration. It did not seem appropriate to try to lower intracranial pressure through venous sinus stenting or through a shunt because, of course, the problem is localized to the optic nerve sheath. So this is a very unusual thing, but if you see a patient where there is a persistent unilateral papilledema like that, CSF sequestration and pressure sequestration within that optic nerve sheath may be what is operative. So in conclusion, I hope this series has helped you to recognize pseudopapilledema better and to develop some diagnostic tools. I did not mention the odds consortium protocol, but it is a published protocol of trying to do various imaging studies to discriminate those discs with optic disc drusen from those that don't have them. We will all do a good ophthalmologic exam before making a diagnosis, and repeated exams may be required or helpful. Most of our IIH patients, when they have true papilledema, they will respond to weight loss and headache management, but we must treat quickly when medical management fails and vision loss is present. And so I want to thank you for your attention, and I'll turn this back over to my moderators and esteemed colleagues. Thank you so much.
Thank you. Thank you so much, Prem, for that wonderful description of disc edema and papilledema. We'll have a quick round of comments or questions, any from our expert panels, before we start the cases. Any of our panelists or moderators have any questions or comments?
I think it was a wonderful talk by Prem as we expected, and he has covered most of the topics. I just would like to have an opinion about the RP Brooks membrane angle with the sclera, like Mike Kofferman has talked about for diagnosing pseudopapilledema from papilledema.
Sure, thank you for bringing that up. And I think that is a very nice feature when it is present, Professor Sharma. And what you're alluding to, of course, is that when we look at those cross-sectional images, normally the Brooks membrane opening is deflected a little posteriorly, or it is flat. But when there is increased ICP, it pushes that Brooks membrane opening anteriorly, and we can see that there is an anterior angulation. And absolutely, I think that that is another tool that when present is very helpful. Thank you.
Wonderful.
Dr. Prem, how much importance will you give to spontaneous venous pulsations when we diagnose papilledema?
I think that when spontaneous venous pulsations are present, they are usually indicative of pseudopapilledema. There are case reports of true papilledema with spontaneous venous pulsations, but I think the absence of spontaneous venous pulsation, or the presence of spontaneous venous pulsation to me is a little more useful than absence, because absence can be there with normal ICP, but presence usually means normal ICP. But again, I take it in the context of everything else. I don't use it as a single sign.
Because when the papilledema is recovering, we often see the spontaneous venous pulsations coming.
Absolutely. And in a patient who lacked them, and then they develop them as their papilledema gets better, I will use them as a sign. If they come back and now the SVP is gone, then that is a warning sign to me that their disease is probably returning.
Sir, I have
Yes,
one
sir.
question, if I may.
Ambika and then Rebecca.
Sure, sir.
Thank you. Thank you, Rashman. That's a wonderful lecture, Dr. Prem. Thank you. And I just have a couple of questions. You had mentioned about this incidental MRI findings of IIH, because that is more and more we see in our clinical practice now. We see a lot of patients referred by neurologists when the patients go for complaints of headache. They don't have papilledema. In these patients, how frequently you keep them in follow-up? And what are the investigations you ask and how frequently?
Sure. So then this is where some of the OCT things and the photographic things that I showed are really helpful. So that what I didn't have time to show was that when you have 3 or more of those MRI signs, then there is a high likelihood that the patient truly has elevated ICP, but 1, useless, 2, And I discussed that with the patient. And if they have no symptoms of elevated ICP, if I think their optic nerves are truly completely normal, then I will just dismiss them. I will discuss the findings and say, please get regular eye care like you are supposed to and come back if something changes. The ones, again, just like everything else, if they're on the borderline, they have 3 signs or more, but they have no optic nerve appearance, I may actually see them back in 6 months because they may have an incipient problem that is coming along. But you're right, it's a bit of a plague on the land now that our neuroradiologists, I love that they have gotten good at identifying these, but it has become a little bit of a challenge for us clinically.
Yeah, Rebecca.
Yeah.
Yes, sir. Sir, I just wanted to ask, like, how frequently you resort to fundus fluorescein angiographies, because they show the disc leak, and that is like pretty much evident that there's a true disc edema. So I just want to know how frequently you do it in your practice.
So I do it in cases which are challenging and where I'm not quite sure, but I have to tell you, I have had a true papilledema fluorescein negative case within the past 5 years, which then kind of shook my confidence in it because it was truly papilledema. And so nothing is 100% is what that showed me.
Thank you, sir.
One more. I just wanted to know for the CSF sequestration, what you had mentioned. Would you ask the patient to go for a LP, or you would to give a trial of medical management, and then you would, because one of your cases you had managed with sheath penetrations. So you did the
No,
LP,
of course.
kept them on medical, and then went ahead for a sheath penetration.
Of course, great point, Ambika. And absolutely, I think that there are some patients who don't have CSF sequestration, they just have unilateral papilledema. You need to go through the full diagnostic and therapeutic algorithm before you move on to surgical treatment. So absolutely, that was a patient where I tried medical management first, and it just wasn't improving, and I was concerned about progression, so I went to surgery. But yes, you're absolutely right. That would be the normal sequence.
Vrinder.
Is there any experience on that newer drugs for weight loss, what Susan has been saying?
Yeah, I
Is there
think
any?
that. So, there was a trial to see if there was some independent effect on ICP with the GLP-1 agonists. And there was a study that suggested that it actually lowers ICP independently of the weight loss. That study has been closed. The company stopped its sponsorship of it. So I think now we're just left with the clinical use of GLP-1 agonists, which certainly my obese patients, when they see their primary care doctors, they're being prescribed this medicine. And so I think we'll never know for sure if it's the weight loss, if it's the ICP lowering effect. I think it will probably be both based on animal studies and initial studies in humans.
Thank you.
We'll have two more comments, Virinder and then Swati.
Thanks, Dr. Ashwin. Wonderful talk, Dr. Prem. So I was trying to add to the comment that you made that from India, whatever the reports come, they say that even in patients with IH, the BMI is usually in the late 20s or might be in the early 30s. So could it be related to the distribution of the body fat versus actual BMI? What's your thought on it?
Oh, great question. And I think that there has been some study to suggest that the body fat distribution is a contributor to the risk for developing IIH, that there have been there were studies published probably 15 years ago looking into that, is whether it's the apple shape versus pear shape that is higher risk, and maybe the apple shape is more associated with the elevated risk for pseudotumor cerebri or IIH. So yes, I think that may be part of the explanation.
Thank you.
Yeah, I
Swati?
think Dr. Virender just read my mind. I had a similar kind of question. So that was a great talk, Dr. Subramaniam. My question was, since in our study, we found most of our patients were around 25 to 27 kind of BMI. But is it the recent weight gain which is much more important than the actual baseline BMI? Because many of our patients showed the history of recent gain, around 60%, 70% of them had recent weight gain.
I think other studies have shown that as well, that recent weight gain rather than absolute BMI seems to be the bigger contributor. And so where I am practicing now in Colorado, Reshman said he spent time with me in Baltimore. Baltimore, unfortunately, has a pretty high rate of obesity. Colorado, we have one of the lowest rates of obesity in the United States. And so my patients who have IIH may not have quite as high a BMI, but they do have the recent weight gain history.
Yeah, thank you.
We have a last comment by Mahesh. Yeah.
Dr. Prem, I have a question. Like, when you do an optic nerve sheath decompression, do you prefer a single eye or both eyes simultaneously? And what is your take on that? And
Yeah,
do we wait?
I will typically do both eyes, Mahesh. I think what you're alluding to is a retrospective study that was published from University of Iowa a number of years ago. I think the problem with that study is that it was retrospective and looking down the line, and we don't know, and they were just looking at disc photos and resolution of papilledema. Papilledema can resolve for two reasons. One, it actually gets better, and the other because some atrophy comes in, and I don't think they accounted for that necessarily. If the patient has bilateral visual loss, unless there's some reason to only operate on one eye, I will typically do both at the same sitting to try to take care of the problem.
Okay, thank you.
Thank you. Thank you so much. Thank you, our expert panel. And thank you so much, Prem, for that wonderful discussion. Let's go to the cases. I'll request all the presenters to stick to their time so that we can generate more discussion as well. And I know Prem has to go a little early, so make sure that let's have him discuss as many cases as possible. So can we start? I think you have been given the sequence, and we can probably start one by one. We have Dr. Sweta Karnavi.
Yes,
Is
sir.
she here?
Yes, sir. I am there, sir. Am I audible, sir?
Yeah.
Yeah. Good evening to everyone. First of all, I would like to thank everyone for giving me an opportunity to present a case today. I'll share my slide. Are my
Sweta, do
shares
you need?
visible?
No,
No.
No.
not
You
yet.
need. Yeah.
Sir, now,
Yeah, it is getting
Started sharing. Yeah.
okay.
Yeah. So can you make it full screen? Yeah.
Yeah. Yes.
The presentation.
Today, I'm going to present a patient of 15-year-old child who came to our hospital with complaining of appearance of black spot in front of the both eyes, due to which she had a difficulty in seeing the board. She also complained of transient blurring of vision and as well as the giddiness when getting up from sitting position, associated with bitemporal headache, on and off bitemporal headache, which was dull in intensity. There was no history of pain during the ocular movements and double vision and tinnitus. On digging the history, we got to know that the child was on antidepressant medicines such as olanzapine and fluoxetine for the panic attacks since 4 months. And also, mother told us that there was significant weight gain after taking the medicines. And she was actually regular patient to our hospital because of the myopia. So she was a known case of myopia and she was using the glasses regularly. There was no significant family history. Her general physical examination as well as the systemic examination was normal. Her unaided visual acuity was 6/36 and it was improving to 6/6 with -2 diopter spherical lenses in the right eye, and it was 6/60 in the left eye, which was improving to 6/6 with -2.5 diopter spherical glasses. Her color vision was normal, but she was giving a slow response, and rest of the anterior segment examination was normal. On fundus examination, the media was clear, but the disc appeared elevated with 360-degree blurring of the margins, and the cup disc ratio was completely obliterated, and veins were engorged and tortuous, and the peripapillary edema was almost more than 3 disc diopters. The foveal reflex was again normal. We sent the child to get the visual fields done. So 30-2 CETA-FAST strategy was done in the child, and this was a reliable field. We showed increase in the blind spot in both the eyes. The MRI brain and venograph was done in the child, which shows prominent perioptic CSF spaces as well as prominent kinking of the optic nerve sheath, and there was enlargement of the optic nerve sheath, and there was also inward bulging of the globe due to the increased pressure. And the MRI venograph was done. The venogram showed mild narrowing of the transverse as well as the sigmoid sinus. The other examination like thyroid profile and the CBC was done, which showed normal findings. There was normal values. So then the child was referred to a neurologist. So after a neurologist opinion, the child underwent lumbar puncture. So the opening pressure after the lumbar puncture was more than 39 centimeters of water, and she was put on intravenous methylprednisolone for 3 days, following which she was put on oral steroids, oral prednisolone, and also she was on tablet acetazolamide for thrice a day. After 1 week of the treatment, she had visited our hospital again, and the visual fields were repeated. So the visual fields showed little reduction in the blind spot areas compared to the last visit. So compared to the adult IIH, nowadays, the pediatric IIH also has become more significant. Like it's almost 0.9% in 0.9 in 1 lakh children.
All right. Yeah. Thank you. Nice case. Prem, would you have given steroids in this patient?
Yeah, I think that the use of steroids in IIH tends in my practice to be restricted to those with very severe optic nerve swelling, to temporize them before taking them to a surgical intervention. That's typically where I would intervene with steroid, and that's usually in a hospitalized patient at that point. So I think otherwise the role of steroid in treating these patients is a little more uncertain.
Thank you, Prem. Any other comment for Shweta's case? Balraj, you can maybe start sharing your screen so that any other comments for the first case? If not, then we'll have Balraj, and we can keep chatting on a Zoom chat if there are any questions or comments. Yes, Balraj.
Sir, my voice is audible, sir?
Yes.
Good evening to one and all present here. I'm going to present an intriguing case of unilateral papilledema. 24-year-old female presented with the chief complaint of sudden loss of vision in the left eye, noticed in the early morning after waking from bed, and there was no history of pain during eye movements, double vision, or not associated with headache, nausea, or vomiting, and no history of drug intake or any systemic comorbidities were elicited. On general examination, the patient found to have underweight. The BMI was less than 18. And the general physical examination, rest of the examination were found to be normal. In the ocular examination, we found grade 1 RAPD in the left eye, and rest of all the investigations were within normal limits, and there was no limitation of extraocular muscle motility. And in the fundus examination, we found disc edema of Friesen grade 3 in the left eye, and the Humphrey perimetry showed a blind spot enlargement in the left eye. And in the optical coherence tomography also, the RNFL thickness is increased about 390 comparing to the right eye. And all the blood investigations were found to be normal limits. Both the infectious and immunological workup found to be negative. And we ordered neuroimaging MRI of the brain with orbit with MRV with contrast, found empty cella and prominent optic nerve sheath fluid. And after that, we performed the lumbar puncture, and the CS of opening pressure was found to be at 25 centimeter of water, and infectious workup and immunological workup also turned out to be negative in the CSF analysis. According to the modified Dandy's criteria, the patient doesn't had headache, and the papilledema was unilateral, and there was no six-nerve palsy, and CSF pressure was just touching the borderline high, about 25 centimeter of water, and the rest findings were normal. Then we had probable diagnosis of IH, but at till 3 months, the disc edema in the left eye was still same. After 3 months, patient started showing a very good response with oral acetazolamide. So fundus examination, the resolved disc edema with peripapillary atrophic changes at 6 months with a good response to medical management, and Humphrey perimetry returned to normal, and the OCT also became normal RNFL thickness at 6 months follow. So IH is a syndrome with an unknown cause, typically affecting the egg obese female of childbearing age group, but unilateral papilledema is present only in 4%. So these are the differential diagnoses we kept at mind while treating the case like optic neuritis, neuroretinitis, optic nerve sheath glioma, and meningioma. And after extensive workup and with lumbar puncture, we came to a diagnosis of IH. A lot of theories were put forward for the unilateral IH. The most common accepted theory for unilateral papilledema proposed by Leopata et al. Because of the abnormality in the optic nerve sheath complex or the laminocribrosoma changes. And Bidot et al. Suggested that smaller bony canal might hinder the CSF pressure, which may be the cause in our case. And our patient had a very good dramatic response to the oral acetazolamide therapy alone. The patient, since she responded to medical management alone, but we kept in mind surgical management. But after 4 months of follow-up, she showed good response of resolution of papilledema. So unilateral papilledema may indicate IH and should be suspected in atypical patients. Early recognition and appropriate management can prevent visual complication and improve patient outcomes in IH. Research needed to further elucidate the pathophysiological mechanisms in underweight patients and potential for developing targeted therapies that address the unique aspect of IH in this population. Thank you, Aios, for giving this opportunity.
Thank you, Balraj. It's I think there's so many atypical features in your case, and probably we'll have the expert opine on it. Low BMI, unilateral papilledema, RAPD. So any comments on this case?
I mean, I think it's a nice case where you showed a appropriate differential diagnosis. And I think that the supportive MRI findings here are helpful, and excluding other things like, not seeing optic nerve enhancement or other features that would lean you more, inflammatory findings in the LP. I think that was more the importance, going back to what why you should do the CSF analysis. I think that was critical in this case, not just the opening pressure being perhaps a little less important. So absolutely, I think you have to be very open-minded in how you approach these patients and not just jump to a conclusion that this is unilateral papilledema from high ICP.
Yeah, Virendra.
Dr. Rashmin, I'd just like to add one small comment here. I think the largest study came out from Emory University, it's Samuel Bidet study, which was quoted by Dr. Balraj. It's a very nice case, but we have to be aware that though unilateral disc edema primarily means that we are going to look more likely to be an ocular cause or a pseudopapilledema, but rarely it could be the effect of a raised ICP transmitted asymmetrically. So about 1.5% of all patients had purely unilateral disc edema out of 450 patients or so in the study by Bidet et al. So we should keep it as the last criteria, as a last thing, but we do have to keep in mind.
Thank you.
Thank you.
Virendra. Sushruth, you're next.
Yes, yes. Good evening, all. I'll be sharing my screen. So hope my slides are visible and they're running properly.
Yeah.
Yeah. So thank you so much, Aios, for giving this opportunity to me. I shall be presenting this challenging case of persisting disc edema. So she's a 70-year-old female, had come for routine evaluation. Elsewhere, she was noted to have optic disc edema in the right eye. She had no complaints of transient vision loss, pain, headache, vomiting, tinnitus, or fever. She is a known case of diabetes mellitus since 23 years, hypertension, dyslipidemia, and hypothyroidism. On examination, her vision was 6/9 in the right eye, 6/24 in the left eye. There was no RAPD. Color vision was full in both the eyes, and rest of the examination were within normal limits. On fundus examination, there was right eye disc elevation, blurring of disc margins, and on retina consultation, she had PFT in both the eyes and scarred CNVM in the left eye. So fields were done for her. There were non-specific peripheral depressed points in both the eyes. USG B scan was also done, which revealed no drusense in both the eyes. OCT angiography and EDI OCT was also done. There was no sign of optic disc drusen. So blood investigations were done for her. Lipid profile, thyroid profile, and everything were normal. ESR CRP was normal. HbA1c was on the higher side, and hemoglobin was 10.4 grams per deciliter. MRI was also ordered for us, which revealed no changes in the optic nerves. A few ischemic changes were there in the brain. MRV was also within normal limits. So in view of persisting, in view of right eye disc edema, intact color vision, absence of RAPD, grossly normal fields, normal MRI, and uncontrolled diabetes, we had a suspicion of diabetic papillopathy in the right eye. So she was advised strict diabetic control and was asked to review back in 1 month. So after 1 month, she had no new complaints, no other signs of raised ICP or giant cell arteritis were there. Her vision and general health were also stable, but fundus still showed persisting disc edema in the right eye. Her color vision was also intact in both the eyes. Her fields were stable. There was just a generalized reduction in the right eye's sensitivity. Left eye had some few paracentral and inferior field effects. OCT RNFL was done this time, which showed increase in the RNFL thickness in the right eye. and normal GCC thickness in the right eye itself. And left eye RNFL thickness was normal, but there was GCC thinning nasally, which could be attributed to the PFT. So the thickness in the right eye was 330, highest maximum thickness 330 microns, and the overall thickness was also on the higher side. Her ESR levels were done, which were a bit high. Her ANA, C anchor, P anchor were negative. RF factor was also done, which was negative. Her CRP was also normal. NMO MOG were negative. So she was advised to follow up after 1 month and advised strict metabolic control. Even in the second follow-up, after 1 month, she still had disc edema. There were no gross change in vision and color vision. No signs of GC or raised ICP this time also. HbA1c was 6.8%. PAM was done in right eye. It was 6/12 this time. The vision, she told a little bit less compared to the first visit. On fundus examination, there was persisting disc edema in the right eye, and fields were also stable. So she was advised LP to rule out IH in view of persisting disc edema. However, the patient was reluctant for undergoing lumbar puncture. So therefore, she was referred to the neurologist to empirically treat. It was decided there to empirically treat her with anti-edema medications. So tablet acetazolamide, 250 tablets, 250 mg tablets, 3 per day were given for her, and she was asked to review after 3 months. So 3 months later also, she didn't have any new complaints. Her fields were stable, vision was stable, color vision also was full. However, the disc edema was found to be reduced in this visit, as we can all see in the fundus images. There was reduced disc edema in the right eye. Fields were stable. Even the OCT showed resolution of the RNFL edema this time around. The overall thicknesses were reduced. EDI OCT also showed reduction in the disc edema. So this was how our progression happened. In the first visit, there was disc edema, fields were stable. In the second visit, still the edema persisted. And in the third visit, after giving tablet acetazolamide, there was a resolution of the disc edema in the right eye. So following are the few causes of persistent disc edema: papillophlebitis, venous stasis, retinopathy, incipient NAN can also have persistent disc edema, diabetic papillopathy, as was suspected in our case. Asymmetrical papilloedema can also present with persistent disc edema. So in summary, our patient had persistent disc edema in the right eye for 8 weeks. She was suspected to have diabetic papillopathy. Even with optimal glycemic control, there was no resolution in the disc edema. So we raised the suspicion of asymmetric papilloedema, and lumbar puncture was advised to her, which the patient declined. So an empirical treatment with acetazolamide as per neurologist consultation was done, which resulted in the resolution of the disc edema. So lots of questions this case raised. What could we be dealing with? Was it diabetic papillopathy in this case, or unilateral asymmetric disc edema due to IH because it showed resolution with acetazolamide tablet? These are the questions which we still have. These are unanswered. So thank you for your patient listening.
Thank you, Shushu. Any
Thank you.
comments on?
So how far you would wait to, close the book as it is not a diabetic papillopathy with normal preserved optic nerve functions? Because this lady, she had a PFT, she had dense cataract, and she was obese. She was 70 plus with all the known vascular risk factors, but yet we were keeping her in a follow-up because she was declining any investigations which had invasive procedure. Even an angio, she refused. So this is how we went ahead, and I just would like to know my friends and Dr. Prem to comment that are we on a track, or do we have to have done something else?
Now, these are challenging cases, just like you said, and I think you did the right thing following along, keeping an open mind as to what the diagnosis might be and intervening when it looked like there was vision loss. So I think, again, this just shows us that even with all the tools we have, it can still be very challenging.
I have a question on this case.
I was,
Yes. Dr. Ambika, if it was a diabetic papillopathy, would we expect a lesser degree of edema, disc edema, and would that be a differentiating feature?
Of course, because she had to begin with, she had a lesser disc edema on her first visit. And subsequently, at the moment when we kept her in the next follow-up, like that is when we started seeing a difference in the edema nature. There was an increase in the RNFL where we, from second visit, we have been priming her to go for an LP because she's 70 plus, and we were literally thinking that she may turn up with a subacute vision loss and come back saying that she's a GCA, but she didn't. So at that age group with so many risk factors, my only thing is like she's having a probable incipient NAION type of thing, or is she going to come back with to us with a GCA picture? That was the only diagnosis, and it came to us a surprise in the second visit when the disc edema increased, and only then we started thinking of a unilateral IIH and kept her persuading for going for those line of investigations. And in other ways, I would like to know from my friends also, like if I have a persisting disc edema with a retained optic nerve function evaluation, like what else you would think in such a condition?
As you have done, we would probably do a complete systemic evaluation, make sure we are not missing any hidden systemic findings, and probably the neuroimaging as you have done rightly, but look more for hidden systemic diseases. And in that particular age, we would be more worried about, as you have also been worried, we'll be more worried about systemic diseases. Yeah.
In fact, probably I felt that what I did not do for this lady is because she had a very floppy lid also and she was obese. So I was just asking the patient whether can you get a sleep study also? Can OSA present something like this, Dr. Prem?
It certainly can. I think that intermittent ICP elevation overnight can be a confounder in such cases. And I agree with you that is an excellent thought in looking into that.
Well, in an afterthought, I was just thinking that I have missed doing that screening for this lady, and I have asked that in the recent visit alone. And she's totally determined that she's not going to get any invasive procedures. So that's why she declined to get an LP itself. Thank you. Thank you.
All right. Thank you. Thank you so much. Nice case. Dr. Aisha, Dr. Mohan is not here. So, Dr. Aisha.
Sure, sir. At the outset, I would like to thank Aios for giving me this opportunity. So, I'm going to present a clinical case of a 26-year-old male who presented to us with binocular horizontal diplopia, which was painless, sudden in onset, and gradually progressive. I would like to highlight the fact that the only presenting complaint of the patient was diplopia. There was no history of headache, transient visual obscuration, nausea, vomiting, tinnitus, numbness, any neurological deficit, hypertension, any medication, sleep apnea, weight loss or gain, COVID-19 infection, smoking or alcoholism. So on examination, his vision was 6/6 in each eye with N6. The pupillary reactions were also normal. There was no RAPD. And extraocular movements were also full and free in all gazes in each eye, except in left eye, there was abduction deficit of -1. The color vision was also normal in each eye, and the blood pressure was also normal. So the patient had left esotropia of 8 prism diopter in the primary gaze, which increased to 14 prism diopter in the left gaze. His fundus picture showed grade 5 papilledema on modified Fresnel scale. So we advised some basic workup for the patient, which came out all to be normal except for mild thrombocytopenia. So in view of a young patient with unexplained neuro-ophthalmological presentation, we advised MRI, brain plus orbit, And we found here that there was partially recanalized thrombus at the confluence of sinuses. Here at the transverse sinus also, it was partially recanalized. Here we can see the thrombus in the wall. And this is the retracted thrombus at the posterior part of the superior sagittal sinus. There is tortuous bilateral optic nerve with indentation, a slight indentation of optic nerve head, which is suggestive of papilledema, as we have already seen on the fundus photograph. So at this point of time, the patient was diagnosed as a case of cerebral sinus venous thrombosis. Now we would like to know the cause. So further evaluation of vasculopathic risk factors were done. We, along with our medicine colleague, but all of them were negative for any vasculopathic risk factors. So the patient was diagnosed as a case of idiopathic cerebral venous sinus thrombosis. And the patient was started on subcutaneous low molecular weight heparin, 3000 international unit BD for 5 days, and then oral warfarin, 2 mg per day. And along with that, we started him on acetazolamide, 250 milligram 4 times per day. So on 10th day, the diplopia resolved, and fundus also showed improvement in the papilledema. So the patient was continued on warfarin on follow-up to maintain the PT-INR between the range of 2 to 3, and the patient is still on follow-up. Papilledema has not yet fully resolved. This was my case. So thank you for your patient listening.
Any comments, questions? Nice case, Aisha.
Isn't thrombocytosis seen more commonly in these patients as compared to thrombocytopenia? I'm not sure.
Sorry, ma'am?
I think it can vary a lot. You can see a number of different hematologic abnormalities. I think the main take-home point from this case is when a patient presents atypically. So the case we had with that very thin patient, as well as here, it's especially important to look into secondary causes and not to come to a conclusion that this is idiopathic intracranial hypertension.
Is Dr. Ann here? Yeah, Dr. Ann, you're next.
Good evening, everyone. Am I audible?
Yes.
Yes.
Start sharing the slides. Second. Are my slides visible?
All good, doctor.
Okay. Good evening, everyone. My name is Dr. Anna Kurian from Little Flower Hospital and Research Center, Angamali. First and foremost, I would like to thank Aios for giving me this opportunity to present this case. This is a case of a 65-year-old male who was brought to our OPD with defective vision in the right eye, which was sudden, painless, and profound of 2 days duration. He also gives a history of sudden loss of vision in the left eye 3 weeks back, for which he consulted a nearby hospital, but further treatment or follow-up was not done by him. There's a history of headache and neck pain. There was no history of flashes or flutters, no history of transient loss of vision, no history of fever, scalp tenderness, or jaw claudication, no history of any systemic diseases. Patient was not on any medications, no history of addictions like smoking. On general examination, the patient was found to be poorly built and nourished. Pallor was present, no icterus cyanosis, clubbing, pedal edema, or lymphadenopathy. PP was 130/70, pulse rate was 76 per minute, normal in rhythm and volume. Patient was afebrile. And on skin and scalp examination, there was prominent nodular, non-pulsatile, superficial temporal artery on the right, palpated on the right side. Clinical examination of the patient showed he had a vision bilaterally, no PL, lids and adnexa, cornea, anterior chamber were within normal limits. Bilaterally, the pupil was 4 mm dilated and fixed, not reacting to light. The lens right eye showed NS2 and left eye it was NS1. This is the fundus image of the patient. In the right eye, there was a hazy media. The disc trace and stripe could not be made out due to blurring of disc margins and disc elevation. There was typically pallid disc edema. The physiological curve was obliterated, and in the peripapillary area, there was distortion of retina nerve fiber layer due to edema, and the fovea reflex was dull. In the left eye, it also showed a hazy media. The disc margins were relatively well defined. The disc was pale. There was a couplings ratio of 0.4. There was multiple yellowish white, ill-defined, fluffy lesions suggestive of cotton wool spots, more in the peripapillary area. The vessels arising from the center of the disc were branching dichotomously with an AV ratio of 1:3, suggestive of arteriolar attenuation, and the background retina was pale. So with the clinical history and the fundus finding, we had a provisional diagnosis of right eye anterior ischemic optic neuropathy, probably arthritic due to the absence of systemic illness, the prominent nodular superficial temporal artery, and the sequential bilateral blindness, and left eye optic atrophy and secondary to arterial occlusion. The differential diagnosis were right eye anterior ischemic optic neuropathy, probably non-arthritic, or right eye optic neuritis with left eye optic atrophy and arterial occlusion, or it may be intracranial space occupying lesion. The following baseline investigations were done for the patient. The HP was 9.6, ESR was elevated, 120 millimeter per hour, CRP was 9.3. And the MRI brain with contrast was also done, which showed no space occupying lesions. So with this diagnosis, we had right eye arthritic anterior ischemic optic neuropathy with left eye optic atrophy, secondary to arterial occlusion due to giant cell arthritis. With this diagnosis, we went ahead with the treatment of induction therapy with intravenous methylprednisolone. 500 milligram was given twice daily dosage, total for 3 days. And for maintenance therapy, we referred the patient to the rheumatologist, and the cardiology workup was done by the cardiologist. So during the course of treatment itself, after we started the IVMP, we did the temporal artery biopsy, which showed sections of artery with narrow lumen, with thickened edematous wall with chronic inflammatory cell infiltrate and epithelial granuloma suggestive of giant cell arthritis. So the take-home message from this case is that in any case with disc edema, with age group above 65 years, you have to keep a differential diagnosis of giant cell arthritis. The necessary clinical history, investigations, and examination have to be done. And also, if you're suspicious of giant cell arthritis, glucocorticoids have to be started immediately, even if you don't have a proper biopsy. The temporal artery biopsy can be done within 3 days of starting IVMP. Even if your biopsy is negative, you do not have to stop treatment with glucocorticoids, because 15% of cases may show negative histology also due to skip lesions. This patient was kept under follow-up. He came for around 2 or 3 visits to our OPD. The vision did not show any improvement. However, his systemic findings like headache and neck stiffness came down. After that, he was lost for follow-up. Thank you.
Thank you, Dr. Anna. Any comments?
In such cases, the choroidal hypoperfusion can be seen with fundus fluorescein angiography, which will show an hypoperfusion because of giant cell arthritis. And was there an history of jaw claudication?
No, there was no history of jaw claudication. We could not do a fundus angiography because of financial constraints from the patient. He could not afford that actually. So.
And the idea of presenting this case is to highlight the importance of keeping a second diagnosis as GCA as a history, because our patient was so unfortunate that he lost both of his eyes, and if somebody could start IVMP as early as possible, we could have saved his life. And by the clinical features, it was the diagnosis is almost confirmed. So we didn't want to burden the patient with more investigations, and ours is a private setup.
Mahesh?
Yes, that's an excellent case presentation. Just I want to add one comment. As ophthalmologists, patients come to us with headaches, and I've seen 2 or 3 patients without ischemic optic neuropathy, having all signs of giant cell arteritis, and we have referred them appropriately to the rheumatologist, and it has been diagnosed as giant cell arteritis without involvement of the optic nerve. So as ophthalmologists, we need to keep this point also in mind, that we can have without AON also, and we being the first point of contact with the patient, probably we have the chance to prevent a vision loss even before it has occurred. That's my comment.
Yeah, lovely. Thank you.
Can I just ask one question? How frequently you see such severe visual loss responding to treatment, and when do you flip on to the next line of tocilizumab? Dr. Prem?
Can you unshare your
Yeah.
screen?
So, great question with the tocilizumab. So tocilizumab doesn't really have an indication for acute therapy. I don't think it has an additive value to corticosteroids in trying to get the inflammation to come down acutely. It really, I do tend to institute it because it is covered by Medicare here in the United States. And so it is accessible to the patient and not a financial burden. And it works quite well in getting them off of the steroids more quickly. But I don't think it has any role acutely.
Can you stop sharing your screen, Dr. Anna? We have Dr. Saili, but thank you. Thank you, panelist. Can we have Dr. Saili presenting her case, please?
Good evening, everyone. I'll be sharing my screen. So, is my screen visible?
Yeah, you can make it full screen, but it's visible.
Yes, sir.
Yeah.
Am I visible now?
Yes.
Thank you, Aios, for giving me this opportunity. Good evening, everyone. I'll be presenting a case on a headache with a twist. So our patient was a 31-year-old female who came to us with complaints of blurring of left side of field of vision, which she noticed since a week, and it was associated with severe throbbing headache. She also had history of sleep disturbances and increased psychological stress. There was past history of recurrent such headaches for which she had consulted a neurologist before coming to us. So she already came to us with a MRI brain and MR venography report done, which was suggestive of hypoplastic transfers and sigmoid sinuses on her right side. The neurologist treated her with painkillers and anti-anxiety medications, but the patient had no relief. So she came to us at her first visit. Her vision in the right eye was 6/9 parts N6. In the left eye, it was reduced to 660 N24. Intraocular pressures were normal. Color vision, red saturation was defective in both eyes, left eye more than the right eye, and the left eye also showed a relative afferent pupillary defect. So perimetry was done, which showed an enlargement of blind spot in the right eye and a total field loss in the left eye. Fundus examination revealed massive papilledema in both eyes with peripapillary hemorrhages. So on the basis of the appearance of the disc, on the basis of the perimetry findings and a normal MRI report, we made a clinical impression of benign or idiopathic intracranial hypertension. So we decided to take another neurophysician's opinion, and their CSF manometry was done where opening pressures of the CSF was very high. It was 46 centimeters of water, and cytology-wise, it was normal. In view of this, 30 ml of CSF was drained, and she was also given IV methylprednisolone and started on tablet acetazolamide 250 mg TID along with NSAIDs and anti-anxiety medications. She was also advised a gradual weight reduction in view of her high BMI and advised to follow up after 3 days and watch for any vision drop. So at her second visit with us at 1 week, CSF manometry had been repeated twice after 3 days and 1 week. Where opening pressures were 37 and 35 centimeters of water. 30 ml of CSF was drained twice, and 2 doses of IV methylprednisolone were repeated, and tablet Lasix 20 mg OD was also added for her. So at her second visit at 1 week, her visual acuity in the left eye improved to 624 N18. Color vision, she was reading 3 to 4 plates in the right eye. Left eye color vision was still defective, and REPD was still there. Perimetry was showing the same defects. Papilledema was lesser than before, with a few peripapillary hemorrhages and few soft exudates. So at the third visit, vision in the left eye improved to 618 N12, and color vision improved completely in the right eye. Left eye color vision was still impaired. Left eye perimetry showed a concentric contraction of the field. Fundus examination showed papilloedema lesser than before. At the next visit, her vision and color vision showed no deterioration. Perimetry in the right eye, enlargement of blind spot was lesser than before, and left eye showed an inferior arcuate defect. On fundus examination, there was mild disc swelling in the right eye, whereas in the left eye, the disc showed a superior temporal disc pallor with thinning and increased pigmentation at the macula. At her last visit with us, vision in the right eye was 6.6 parts N6, and left eye vision had improved to 6.12 N8. Color vision in the right eye was normal. Left eye had improved to reading a few plates, and perimetry was stable. Fundus examination revealed mild temporal disc pallor in the left eye more than the right eye. So the patient has been now asked to follow up with us after 3 months for perimetry and fundus examination, watch for any visual deterioration, and she has been continued on tablet acetazolamide. So I'd like to elaborate a few points about idiopathic intracranial hypertension. It predominantly affects obese females of childbearing age. Neurological examination is normal, except it can be associated with a non-localizing uni or bilateral sixth nerve palsy. Papilloedema being the hallmark sign is usually bilaterally symmetric. The diagnostic modality of choice after a complete ocular examination is MRI brain with contrast and a venography. CSF analysis is necessary to rule out the other causes of raised ICP. And goal of the treatment is basically to reduce the intracranial pressure and preserve vision, as chronic and recurrent cases can lead to permanent vision loss. Thank you.
Thank you so much, Dr. Sally. This case highlights a little different approach that a lot of neurologists would like to take in cases with raised intracranial pressure. That is, as we were discussing, the role of steroids, which is quite controversial, and frankly, a lot of people would avoid using steroids in cases with raised intracranial pressure. Also, there are people who are keen, or they generally do this repeated lumbar puncture as a mean to reduce the pressure. I don't know what's your opinion, any of the expert panels, whether that's something which should be advised, because I think that's a repeated LP. I don't think is as a therapy. I don't know whether it has any major role. Any of the panelists?
In this case, since the opening pressure was very high, and patient had a significantly reduced vision, so the lumbar puncture was repeated. I would like to ask Dr. Ashwin one thing. Do you do ultrasound for measuring the optic nerve sheath diameter, especially in cases for diagnosing papilledema?
So I personally, or our section where I work, we don't have a major experience with this. I know Jyoti Matale in Bangalore is very, she recommends doing ultrasound, and she has a good handle herself. Ambika, are you doing it at SN?
No, we don't do for a clear papilledema case. For the diagnosis of papilledema may not be. Since grade 3+, there's no role of ultrasound for us to make the diagnosis. Maybe grade 0 to 2, yes, where you have a doubt whether it's true or pseudo, there is a role of ultrasound. And when you don't have access for the other investigative modalities like an OCT or or if you're not going to image the patient, just to ensure that you're not missing any other cause, or if there is a suspicion of any associated uveitic entity, because we see a lot of times VKH misdiagnosed as IIH and it's mutually interchangeable. We have a lot of these uveitic entities presenting with disc edema. Yes, there may be a role of ultrasound in that, but not as a papilledema. Per se, there is a role for, not frequently we do.
Exactly right. I think what Madam was probably asking was the 30-degree tilt test, which a lot of people are advising. We don't have the direct experience. I don't know if any of the other panelists.
We do that if it is really where we can't, because we did that for a patient where patient was not willing for a MR and she was a claustrophobic patient. So we had to put her for a CT and we were suspecting her an IIH. So there we use this 30-degree, but we don't do it as a routine.
Exactly.
Would anyone manage the case differently? Would a peritoneal shunt in such a case would be helpful, or the way it is managed, feel it is the way to go?
So I think the point was that, yes, I agree that since the pressure was high and then there was a vision loss with RAPD and all, an aggressive intervention was required. Now, whether the aggressive intervention would be steroid with LP, or would it be direct surgery, would it be fenestration, would it be lumbar puncture, as Prem mentioned, whatever is available to you and whatever is your expertise is what. But yeah, the bottom line is that it required an aggressive approach, and that was done. But as I said, I don't know whether repeated LP with steroid, at least our group is not doing it here. So. But yes, as you are saying,
because every time the opening pressure was much higher than the normal. All the 3 lumbar punctures, they had a pressure above 30.
Was there a lumbar drain or something, Dr. Shubhangi?
Yes.
Was there a lumbar drain for the patient?
They didn't put a drain. They just did a lumbar puncture and drained 30 ml of CS.
How frequently she had?
3 times it was done. 3 times it was done by the neurophysician in first week.
Within 1 week?
Yes.
Can I make one comment, Dr. Ashwin, please?
Yes.
I think maybe with such kind of high pressure and severe vision loss, probably we are dealing with fulminant IIH over here. And in these kind of cases, probably doing shunt surgery may be much more beneficial than, going with medical management therapy, because it does need very aggressive kind of treatment, because there's a rapid loss of vision there. So of course you have to give medical routine management, what we do, but it may be better if we can do shunt. Even ONSF, I'm not sure what is the experience, but even ONSF in these cases may not give such a good prognosis.
Patient was not very willing for any surgery. So that also was one factor.
Yeah, that is another
psychologically upset, some internal problems in her family life. Would that be a bearing on the development of IIH? I wanted to ask. The stress, psychological stress or something.
Can't comment, not sure. I don't think. No studies as of now.
Unless she had some sleep disturbances and severe sleep apnea.
Yeah, indirect. Yeah. All right. Thank you. Thank you, ma'am. Thank you so much. We have a second last case, and Rebecca, are you ready?
Yes, sir. Right. So, getting onto the case quickly. Slideshow. Yeah. So, a very good evening, everyone. My case is an old male patient in the late 50s who presents with the chief complaint of sudden onset, bilateral decrease in vision, and also increase in the periorbital swelling for past 4 days. And basically all these symptoms happened within 24 hours after receiving rituximab. So the patient was given rituximab along with the standard pre-medication, which is given at our IRCH, that means the Cancer Institute, which is injection hydrocortisone, injection phenyramine, and tablet paracetamol. So despite the pre-medication, the patient developed these symptoms. Now coming to the past medical history. So this patient was a known case of a non-Hodgkin's lymphoma, that is the mantle cell lymphoma, and was treated with the R-CHOP regimen. So patient did show a response. Initially, rituximab was given frequently every 20 days. After he showed response, it was converted to a maintenance dose of rituximab every 2 monthly. Now, what happened that during the maintenance phase, the patient suddenly developed proptosis. And a biopsy done for the proptosis and periorbital swelling showed that there was a lymphoma, orbital infiltration of the lymphoma. So this was earlier. But when the patient, for this orbital infiltration, so there was a relapse of the lymphoma in the orbits. So when for this relapse, again, the patient was restarted on the treatment dose of rituximab, he developed sudden increase in the swelling. So this is the baseline photograph, which shows mild proptosis and periorbital swelling. So that is suggestive of the orbital invasion of lymphoma. And after the rituximab, there was a marked increase in this swelling. So what we see is a lot of chemosis, lid congestion, marked limitation of the movement. And just have a look at the vision. Pre-treatment, the vision was around 6/9, 6/12, and the vision dropped to 1/60 and no PL in the left eye. IOPs were also markedly elevated. Pupillary reactions were sluggish, anterior segment was normal. Fundus, if we have a look at the fundus, it appeared to be grossly okay. As of now, when the patient presented to us, it appeared normal. VER showed a prolonged latency in the right eye. There was no response in the left eye. This is the neuroimaging. We repeated the neuroimaging for the patient, and what we found was that there was a marked inflammation. So this is what you see is a soft tissue inflammation all around in the preseptal and extracorneal compartment. But what you also notice is a marked inflammation. So this is your T2 hyperintensities, and this is the post-contrast enhancement that is noted along the bilateral optic nerves, left more than right. And it's not involving just the optic nerves, but there's also involvement of the surrounding fat tissue, soft tissue, and also. So some kind of inflammation had definitely increased following the treatment. So this is just a comparative picture. This was the imaging that was done pre-rituximab, and here we just see the soft tissue infiltration, which I just described. But there is no intracorneal involvement here. The intracorneal area is clean. But post-rituximab, you see a marked increase in the swelling and extensive inflammation happening bilaterally in the orbits. So the patient was suspected to have this rituximab-related neuritis and inflammation. And also another feature that we notice is this conical configuration of these globes that indicate that there was a marked increase in intraorbital pressure that was compressing the optic nerves as well as the structures in the orbit. So the patient was immediately started on IV methylprednisolone, considering that there was an inflammation, 1 gram for 3 days, and then patient was shifted onto the maintenance dose of oral steroids. So this is the 1 month clinical photographs, the 9-gaze photograph. As you can see, there is a marked improvement. Patient, the swelling has gone, it's much better. And vision improved in the right eye to 636, but left eye still remained no PL. And the patient completed the rest of the rituximab cycle under the cover of a stronger steroid, that is IV methylprednisolone, rather than hydrocortisone. So coming to the discussion, rituximab, as we know, is an anti-CD20 monoclonal antibody. So it is it's a very important drug that's used for lymphomas, leukemias, and also being used as off-label in several autoimmune diseases like rheumatoid arthritis, Graves' disease, myasthenia, refractory cases of uveitis and scleritis. So what's the mechanism of this anti-tumor effect? So basically some antigen-antibody reaction is happening between the rituximab and the B cells. This results in the massive release of cytokines, the pro-inflammatory cytokines that may sometimes cause fulminant inflammation. And several side effects have been reported, like worsening or exacerbation of an underlying autoimmune disease for which rituximab was being given, like SLE, neuromyelitis optica, painful eyelid edema and scleral edema, rise of IOP, progression of inflammation, chemosis. So all this has been attributed to the release of cytokines and inflammation that is happening following rituximab. Now, another intriguing feature is that all these things, all this inflammation or worsening of inflammation happens in the site that is already affected. So in our case, it was the orbit because there was orbital infiltration of lymphoma. So why so? Because there is already a B cell infiltration at these sites. So there is greater rituximab uptake at these areas, and that results in greater inflammation in these areas. So finally, the cause of vision loss in a patient, well, we could say that it was related to this massive inflammation happening related to the cytokine release that not only led to the optic neuritis bilaterally, but also it led to the orbital compartment syndrome. So the important take-home message is that rituximab may rarely cause sight-threatening inflammation, especially if the patient has orbital involvement. So that must be kept in mind. And in such cases, other than the standard pre-medication protocol, we may switch over to stronger IV steroids like IV methylprednisolone to avoid any vision loss in these cases. Thank you.
Thank you, Rebecca. Thank you for that new dimension to rituximab. Any other experience, comments?
Just say that rather than calling it rituximab-induced optic neuritis, it would be better called as a relapse, which is because of the rituximab, because there's a surge of the cytokines in probably the blood-brain barrier, they say, is not completely taken care of. And that's why it happens. So when you use the word optic neuritis, it may limit it only to the optic nerve. Here it's much more fulminant inflammation all over.
Right.
Any other comments?
I think we have just seen one case, so it's quite rare. So that but must be kept in mind.
Yeah.
Thank you, sir.
Thank you, Rebecca. Thank you so much. So now we come to the last presentation of, we have Dr. Michael Gilhooly, who is joining us from Denver. Michael, all yours.
Thank you. Let's get the slide ready. Right, so good morning. My name is Michael Gilhooly, and I'm the Neuro-Ophthalmology Fellow here at the University of Colorado. I'd like to just thank the INOS for inviting me to speak after Professor Subramanian's presentation there as well. So what I'd like to do is present a case that we actually saw this week in the clinic. First of all, giving you some background to what had happened to the patient before they arrived with us, before how they were assessed, and allowing at the end the panel to discuss what they thought may have been going on and to discuss a sensible plan. So in terms of background, our patient is a 41-year-old woman who's a physiotherapist by profession and has had around 2 years of intermittent symptoms. Now, she describes them as a sensation of pressure on leaning forward or standing up, and these can be associated with momentary disorientation. She quite adamantly denies headaches. Many of the doctors she's seen before have asked her about her headaches, and the first thing she says when she comes into the clinic is, "I do not have headaches." She does, however, have occasional pulsatile tinnitus and can have transient visual obscurations when standing. Her past ophthalmic history is notable only for a PRK for myopia many years previously, and her past medical history generally good other than 2 very complicated pregnancies, which she had delivered safely in the end. So in terms of her background, she saw her general practitioner locally. She lived several hours from the city here in Colorado. Saw her local doctor who examined her in terms of her complaints and noted bilateral disc swelling and ordered an MR imaging. Now, this demonstrated a couple of features that could make people suspicious of raised intracranial pressure. She had an empty cellar on her MR imaging, as well as a stenosis of the transverse venous sinus. There was, however, no space-occupying lesion. So from here, she was referred to a local neurologist who incited further investigation. And this included a CT venogram, which redemonstrated the previously known venous sinus stenosis, but refuted any presence of thrombus. A lumbar puncture was undertaken with an opening pressure of 26 millimeters of water, but with bland constituents. And with this constellation of findings and symptoms, she was trialled first of all on Diamox, which was unacceptable given side effects, and secondarily to pyramate, which she often also found impossible to take given the side effects. So she was ending up on methylzolamide at 150 milligrams twice a day. And at this point, she's referred up from Colorado Springs, which is a smaller town 2 or 3 hours away to Denver, to come and see the neurosurgeons here with a consideration of placement of a stent. And she arrives, sees the neurosurgeon, who first of all requests, can we have a neuro-ophthalmic assessment? And she arrives in our clinic. So what we find on her presentation is a well-nourished but physically fit young woman. She's a physiotherapist and her BMI is essentially normal. She has good visual acuity, full colour visions, and her ophthalmic examination is to all intents and purposes normal. Her fundoscopy, however, does indeed demonstrate raised bilateral optic discs, but without any obscuration of the vessels. OCT was performed, which as we can see has several features, especially in the right eye of what may well be an optic drusen, and in the left eye, fullness peripapillary, which may indicate the POMS diagnosis as well. She gave visual fields bilaterally, which showing a generalized reduction in sensitivity, but no focal scotoma. So with that brief case presented, I leave this to the panel to discuss both their slightly atypical symptoms and signs, what they think of the optic discs, and indeed at this point the question that we were asked is, should this lady have a stent or not to deal with her symptoms?
Any comments on whether would you, so here is a patient who does not fit into a typical BMI patient profile, not complaining of headaches, but of course tinnitus and transient visual obscuration. So there are few features which we say maybe there is a raised tracheal pressure. And the optic disc, we didn't see the color photograph, right? Did you
No,
show
unfortunately, we didn't have a color photograph for this patient, actually, I'm afraid. So it's just the black and white, the red free. Yeah.
All right. Okay. Yeah. So, yeah, ma'am, sir, would you, Mahesh, any comments on would you have done this?
I don't think we'll stent in this patient. Medical management should do.
Would you say that this is not even a raised ICP at all? Would you say it's a pseudo disc edema and just observe what? Any other comments?
Opening pressure was 26, I believe.
26, yes.
What was the visual field like?
Yes. The visual fields were essentially full. She had a sort of generalized reduced sensitivity, but no focal scotoma.
I would Michael say there was a little enlarged blind spot.
Enlargement of
yes, it's a marginal enlarged blind spot. Yeah.
So did she do well with the medical management, and how long she was tried on it?
So we saw this patient last week, but she had been on some form of medical management for the best part of a year. And she was adamant that none of these medicines were helping with her symptoms. Now, she was a physiotherapist and she'd done a bit of reading about IH, and she was convinced that she did not have raised intracranial pressure. So every doctor I see keeps asking me about my headaches, about how they are when I lie down. I don't have headaches. I just feel a little bit funny when I stand up. And I have this every so often pulsatile tinnitus. So it was quite an interesting interaction that we had a semi-expert patient who had come up from the country to the city, because the Colorado is, there's everyone lives in the city and then there's lots of smaller towns hours away. She'd come all this way up to try and find a doctor that would listen to her essentially. So Yeah, her symptoms were not typical for IIH, and she had these controversial discs that had some features of pseudopapilledema. And perhaps one of the worries was there a small amount of swelling on top of a pseudopapillodematous picture? And there was really a quite heated discussion about what the best management was here. Was this truly IH? Should she have the stent or continue on the methazolamide that she'd been on for some time with no effect for her symptoms? We also didn't have any records from the initial presentation. Were the discs more swollen? But she's been on medical therapy, and what we're seeing is just the pseudopapilledema that's left after her papilledema, because of a raised pressure, had reduced afterwards. So the eventual decision here was to kind of not make a decision and push it down the road. She didn't have the stent, but we agreed to see her in 3 months' time to have a serial examination and see how she is on those medications.
Was insufficiency of bacillary circulation ruled out? So she had
It had been noted on the referral from the initial neurologist that she'd had venography and a MR imaging as well to rule out other insufficiency.
So I have a question. You said the patient was not happy with the resolution of her symptoms. Is that right? So,
yes.
Yeah, in spite of the disc edema resolving or moderately resolving, as to what we are saying, how do we help the patient? Like, she's not getting better with the medicines. So how do we resolve her symptoms and make her feel better, apart from the medications you're giving?
A very good question. And we again recommended one thing that helped her was finding a group of doctors that agreed that she didn't need to have a venous stent or a nerve fenestration. She relieved her certainly. But what we did do was request an ENT evaluation. We hadn't gone into much detail, but the context of her symptoms, she was saying on standing up, she used the word dizziness to describe what she was feeling. She could often feel off balance for a few seconds. She would find it difficult to walk steadily for only a few seconds after she stood up. So one of her first requests was to get her to see her local ENT doctor to have a full kind of dizziness assessment. I think on examination, there was no nystagmus, there was no obvious off balance in her gait. In our clinic, we could see any definite physical sign that would explain that. So that was one avenue we took in terms of symptomatic relief. In terms of the fullness in the head, she did find simple painkillers like paracetamols were useful for her. But yes, that was the big question: how do we actually help this lady with her symptoms? And that is a kind of an ongoing process at the minute.
Was she on a since she was a physiotherapist, so was she on some specific diet, a calorie deficit diet or a high protein or something of the sort?
We did ask about her diet. She wasn't on any particularly special diet. She wasn't vegetarian, but didn't eat a lot of meat. But maybe once or twice a week she would have meat. So a relatively balanced diet she was on.
So probably she had the dominant symptom was this unsteadiness, imbalance, and mild headaches, which she felt that he settled with the medication. So, which means she had a venous sinus stenosis. How many sinuses were involved? Was there a record of the TSG from the interventional neuroradiologist?
We didn't have the record of the venous gradient. I think it was
because that would help us in deciding whether to stent or not. Because the TSG will give us a lot of clue, and she's already too asymptomatic for that level of stenting. Her pressure is not that high, optic nerve functions are good, headache is not there, and you're still not clear whether it's really a tinnitus because you have to rule out the other causes. So probably we can watch this patient on the medications and then re-evaluate the entire function test and the MRV, probably a contrast enhanced MR venogram in the subsequent visit will be more useful, and a DSA if required down the line.
Thank you. Thank you, ma'am.
Perfect. Any further questions, comments on any of the cases? If there are no, I think we have reached the end of the webinar. So thank you so much. Thank you, Aios. Thank you all the panelists, experts. Thank you, Dr. Sharma sir, for chairing this session. And thank you all the speakers for coming up with some very interesting cases and a great discussion. Thank you so much. Thank you. I have a great evening ahead.
Thank you.
Thank you. Thank
Hope to
you.
see you all in Chennai for Aios.
Good night.
Thank you. Bye.
It is coinciding with POSN. Same dates.